Welcome to Black Health Matters. I'm your host, Darryl Armistead. This is a Howard University Hospital transplant support group session led by Dr. Clive Callender, who is a noted transplant surgeon and professor of surgery at Howard University College of Medicine. Let's join today's session in progress.
One of the things that people don't realize also is that if you are a heavy drinker and you suddenly stop drinking, that also causes its own problems because we have I remember recently a hiker who was a drinker who stopped drinking, actually had convulsions and died from complications from stopping drinking. So that um, alcohol has its problems, but suddenly stopping it can also have its problems. But the greatest evidence is that if when you stop drinking, that your brain generally can recover from the fact that you've been drinking too much. But there's little question that any drinking at all is damaging to the brain. But the good news is that if you stop drinking, that your brain is likely to recover and you'll be okay, even though you were a drinker at one point. Second article that was of great interest, I thought. We talked a lot about microplastics, and for the first time, there's an article that identifies 6 ways to reduce the exposure to microplastics. And some of them, I think, you have already discussed. One is using wooden instead of plastic cookware. I don't know anybody who does that, but anyway, that's a thought because it's the plastic cookware that gives you the microplastics. Second is use glass instead of plastic food containers. And this is the second way of doing it. Third is to use stainless steel instead of plastic blender cups. And then the fourth way is stainless steel, also instead of plastic water bottles. And then having dried food instead of canned foods. So those are some ways that you can begin to start reducing the exposure to microplastics, which seems almost inevitable, as 97% of the American population is contaminated with microplastics, primarily because of the plastic products. Any of you tried any of these ways of reducing our exposure to microplastics in food?
I've started a glassware to put my foods up in. And the other
How'd
part.
that work out, okay?
Mhm.
Anybody else try anything?
Yeah, I've tried just about all of them, but I didn't hear the last thing you said about skin food instead of canned. What was that?
It
I
said
didn't understand what you
dried
said.
foods instead of canned foods.
Oh,
That's
dried
what,
instead of canned. Okay, thank you.
yeah, that's dried instead of canned foods. Stainless steel instead of plastic water bottles, stainless steel instead of plastic blender cups, and glass instead of plastic food containers. And then wooden instead of plastic cookware. I'm not familiar with that, but that is also another way. Dr. Perez, welcome
Good
back.
morning, family. I noticed in Puerto Rico when the NMA had their convention that there were a lot of stainless steel bottles of water The hotel used plastic, which I'm sure was cheaper, but the stainless steel, I saw that in major supply. The other thing, Dr. Callender, as you should know, many Bayesians um, only cook cuckoo with wooden sticks, and I couldn't think of making cuckoo without using using a wooden utensil. But absolutely, making the transition for many of us is also expensive, because going from many of the disposable things that we would get would take out food, now we have to change and use glass. But they're finding microplastics in everything, and it's scary.
Okay, John Buchanan.
Yes, I took Darryl's suggestion to transfer my cooking uh, utensils from the non-stick pans that I had. I got a set of is it titanium pans, pretty darn expensive, and it takes getting used to using it. But yeah, I followed up with that, and even though I tell you, it's hard to not use that non-stick um, cookware because it's so convenient. But I'm every time I use it now, I'm thinking about, well, I'm just eating a bunch of plastic, so it's getting better. Thanks, Darryl, for that
Okay.
suggestion.
Darryl, you had some more comments?
Yeah, the Tupperware plastic food containers. I switched all of that out with Pyrex, and you can get that from Amazon pretty cheaply. And another alternative to the nonstick cookware, besides the titanium, is just to use cast iron, and you just have to cure your cast iron skillets. But that's the old-fashioned way, and it works great.
Okay, thank you. Uh, the next article was about for men on this. Uh, there's a lot of talk about testosterone, and as you know, talking about giving it to the veterans. And so the question is, why all this to do about testosterone? And uh, testosterone is the major male sex hormone, and it is important for maintaining muscle mass, bone health, and supporting sperm production in men. And in women, it increases the libido and energy and the mood. And uh, factors that cause testosterone levels to fluctuate in men and women. One is your age. If we get over 40, the testosterone levels tend to start decreasing, although the best way to tell that is to get a blood level for testosterone. Uh, uh, the more sleep you get, closer to the 7 hours, 7 to 8 hours that is recommended, the more likely you are to have a normal testosterone level. The less sleep you have, the less testosterone you're likely to have. And then the testosterone peaks in the morning between 6 and 7 a.m. and drops off after after 8 p.m. And daylight and summertime, uh, testosterone levels increase. And for some strange reason, when you become a parent for men, their testosterone level decreases. Uh, Surprisingly, if you exercise too intently, this also decreases your testosterone level. And then, of course, The other thing is diet, uh, a healthy diet with a lot of fruits and vegetables, uh, and being uh, lean protein sources also increases your testosterone. Drinking too much alcohol decreases your testosterone, and uh, some medications like steroids and opioids reduce your testosterone level as well. And any comments about the testosterone? You see a lot of advertisements these days about testosterone, and the only way to know whether your testosterone level is normal or not is to get a blood test to find out whether it's normal or not. John Buchanan?
Yeah, I was wondering, Dr. Callender, why Trump wants the military uh, to take testosterone, and is that only for the male service members?
Yeah, yeah. We talked about that last week, and the evidence now. There was a time when people felt that testosterone caused prostate cancer, but now we've got a lot of evidence that testosterone by itself is not. It has no negative effects if you take testosterone, and it does not cause prostate cancer. And so, because of that no longer being an issue, Kennedy thinks it's safer to give testosterone to keep the testosterone levels up. Of course, we had some negative discussion about that last time because I think Colin or somebody else had some negative experiences as a consequence of the males being too manly and assaulting too many of the female military members. Any other comments or questions about the testosterone issue, which I thought was something that you see so many commercials on testosterone. You have to uh, really begin to wonder why all this to do about testosterone. The third article that I thought I should share was that uh, what you should know about cancer risk when you have multiple family members who have cancer. And one of the most important factors to remember is that 90% of cancer cases are not due to inherited genes. So although you may have it in your family, uh, cancer is inherited, but 90% of the cancers are not inherited. But there are the variants of specific genes that are linked to a high risk of cancer, and which requires uh, keeping finding out whether you have some of these genetic diseases, and if you do, whether you get a preventive mastectomy or ovary removal, as has been thought by some, is as or whether you get colonoscopy. These are some of the things that you do. You get uh, cancer screening uh, with breast cancer imaging starting at age 25 if there's a history. And so just knowing your cancer risk becomes important. Your family history about cancer is important to share and let others know about it. Any questions about that? I thought that was a topic that we haven't talked about recently, but it's a topic that is worthy of discussion because so many of us have cancer in our families.
Mhm.
Any comments or questions about the cancer risk? Probably a few families that don't have some cancer a patient, some family members that have or have had cancer.
I know, I know with me, my sister had ovarian cancer. So, of course, the females in the family were concerned about that. But my sister was tested for the BRCA gene, and she didn't have that. And the doctor said that they felt that there was no immediate concern to worry about it being a hereditary situation. So I don't know.
Yeah, that's accurate. Okay.
Mhm.
Any other comments or questions?
Dr.
Carol?
Callender? Yeah, what about the doctors that ask women if they've had cancer in their family before breast cancer and recommend that they have mastectomies, or is that prevalent or is just something that I
That's
heard?
recommended if you have the genetic predisposition to it. If you have a BRCA or any of those genetic uh, that increase your likelihood of having breast cancer or ovarian cancer, then as you know, Angelina Jolie had a preventive mastectomy and ovarianectomy. And so those are things that can be done if you find out that you do have a genetic predisposition to it. Because having a predisposition to it does not mean that you have it, but it increases the likelihood of you having it. And one way to avoid it, therefore, is to have a preventive mastectomy or preventive ovarianectomy. Any other comments? You know anyone who's had a preventive mastectomy or preventive ovarianectomy, oophorectomy?
No, I just read a lot about it, and women are going ahead and elect because people, their mother, aunts, and everybody's had it, so they go ahead and get the vasectomy. But I guess this article is not saying if they're predisposition, or what is this article saying?
Well, as I was saying, that if you had that predisposition, that uh, people are doing that now. They are having preventive mastectomies and they are having preventive oophorectomies to prevent it. If you find you have a BRCA gene or you have one of those other genes that is gives you an increased likelihood of it. I haven't heard many people of color who've done anything about it. Dr. Perez?
Uh, Quite the reverse. Many of the young women that I know that have had breast cancer know other women who've had multiple episodes. So they are opting for preventive mastectomies. And um, I would say the vast majority. I was very surprised how many of them are opting for it.
Well, so many of our young Black women are dying from breast cancer. It sure makes a lot of sense to me because I tell you the number of uh, surgeons that I've trained who later turned out to have breast cancer and died from breast cancer is frightening. And so I understand their wisdom in doing that. Any other comments about it? But it's food for thought and something that is worthy of educating about. Okay, if there are no other comments or questions, I guess we can go to the articles, John. This, of course, is a challenging topic. What do you say to somebody who's dying? And it's a very good article that talks about the wisdom of not talking too much, but yet being willing to talk about your appreciation for those people who you love who are in the process of dying, and that uh, and they mentioned four things that you should say without question. One is forgive. Uh, I forgive you. Uh, Uh, Thank you for everything you've done. I love you. And those are some of the words that are very common because uh, those are things that you should want to share. That how you've really made me happy. Our friendship has been great, and the positive things about it. And so I think this is the important thing is to be there for the person and then to share what you've shared with them for their lives. And this is something that I know that in Black families we say "I love you" all the time. So, but thank you, and I forgive you things that a dying person wants to hear. And, uh, any comments or any other additional thoughts that you think that you'd want to share about with someone who's dying? I know for a while I had to resist from visiting people when they were dying because they often thought of me as somebody who was trying to get organs for transplantation. So for some people, I didn't visit them because they would think I came there to get their organs. But other than that, it's good to be there for people who you love and who love you. That's first.
So often we think that, uh, especially culturally, that if I accept your dying, I no longer have faith in your healing. And I'm hoping that changes so that we can be there for those who really want to talk about the experience and what they're going and the final surrender. I know the daughter of someone I went to kindergarten with, when she decided that the pain was too much to continue fighting. Yet, how do you translate your giving up? She was concerned on how her family would feel that she had given up, when in fact she was surrendering.
Okay, anybody else want to share? Okay, well, I think it's so important to be able to share with people who are dying and the fact that we're all dying anyway. So it's a matter of in life there is death, and so saying I love you and I forgive you and thank you, things that we ought to do all the time anyway. Colin?
Good morning. What I had to say is kind of on the subject. It came from watching John Oliver, and this has been about a year ago. And he was saying that doctors would put people in hospice who, because of the money that Medicare paid, but they weren't really ready for hospice or they weren't really dying. And it was just, I guess, to milk the system. That's not exactly what we're talking about here, but it's something that, I don't know if there's anything that we should be concerned about or just leave it alone.
I don't have any experience with that, so if somebody does, they can share it with us. Joyce, you had a comment?
Yes, well, my brother was in the hospital, in very critical condition. My cousin, who rides motorcycles, he came to visit him while his group was getting ready to have a trip. And James, he was dressed in all black from head to toe. James saw him and he thought he was Satan. He immediately went into a fight mode. They
Really?
had to give him some medication to calm him down, and
Mm.
we had to ask my cousin to leave.
Mm.
So I'm saying that is, we never know the mindset that a person is in during that stage of their life. So we need to be cognizant of what we wear when we see them, when we go to visit them.
Thank you for sharing, John Buchanan.
Yes, I remember going through the end of life of my mother, and I went to Holy Cross, and it was a shock. I wasn't prepared for it. They have a team that uh, it's supposed to be to help you to accept and work through the death of a loved one in advance. They call it palliative care.
Yeah.
They really didn't talk about what to say to the person who's dying. It was more about the family member or the loved one, uh, a friend of that person, rather than what to say to the person who was dying. So I think this might be something that the palliative care people should add to their presentation. Thank you.
Okay, thank you for sharing. Carol?
Um, yes, there's always this statement that's made. They lost their will to live, and that's consequently they died, or they fought real hard, or I know I'm going to die, but I'm going to fight real hard to beat it. Your thoughts on that? How much do we actually, as an individual, have on whether or not we're going to pass? Is it our will to keep living, or we just lose the fight, and because in our mind we've stopped wanting to breathe, or whatever they mean when people say that? What are your thoughts, you and Dr. Perez? What do y'all think about that?
Oh, I think that death is an important part of life and that we're all dying. And so we all need to be aware of that. And there's a time for all of us to go. And we should do our best to prepare for it. Uh, and so uh, giving into it is when you're called to die, then it's your time. In terms of uh, giving up is an interesting concept that some people have. It's a concept that is true for patients, it's true for doctors, it's true for everyone. And so I think it's a very individual thing. And when you accept the fact that you're dying or you're going to die, then that's up to you. So I think it's a very individual thing, and we shouldn't really be judging people in terms of their decision to live or to die. That's my thought on it. Janice, do you have thoughts? Janice disappeared.
Unmute that,
A
Janice.
week or so ago, the person who raised David, Lucy, we called her Sweet Miss Lucy. Lucy was 95 years old. Uh, Loved to party, loved to dress. I mean, she was always very elegant. Then she had nails. I think her nails were about a foot long, but that was her trademark. And everybody knew and loved Lucy. A few months ago, she had a stroke and she didn't quite come out of it, but she kept saying, I'm 95 years old. I've had a wonderful life. I've done many things. They're not going to be cutting on me. And of course, the doctors didn't want to cut on her. They sent her home for palliative care. What's palliative versus hospice?
Okay, palliative care, we've talked about it in the past, but palliative care is care that prepares the family and you to uh, get treated as long as possible, and then also prepare you and your family so that when the treatment is over and we've done all we can to prepare you for the end. So that palliative care is the first stage in which you and your family are prepared for doing everything we can to keep you alive, but also recognizing that there's a time that that will come to an end, and that hospice is when they think that you have less than 6 months to live. And that's
Mhm.
what, but uh, hospice is a part of palliative care. But the first part of palliative care is to do the best they can to treat you and keep you alive and keep you pain free.
When they sent her home, they said she had 14, maybe 20 days. And they sent her home on a Saturday. That Sunday morning, I just felt her. I went to visit her. I sat with her for 2 hours and we talked. And I would think sometimes at 95 years old and you know you're dying, they might drift or may not know what they're saying. She was as lucid and talked as clearly as you and I, but very low, very slow. And she talked about her life, talked about her past. And she said, "Get that necklace over there and put it on me." Well, the necklace was a rosary. And then she kept saying, "I'm going to leave here and I'm going to go see David." And then she said, "Give me that pad and pencil." She started making notes. She wanted a white casket. She wanted this, she wanted that. And this is 95. The next day, she was gone. She went to sleep that night and didn't wake up. But she kept saying she was ready. And then when a nurse was coming in to check her, when the nurse came in the day we called her first to say that she was gone. The nurse was in tears. She said, "I knew she had more time." So does the individual really know? Do they give up? But in her mind, she was prepared. It's time for me to go. I had 95 years. So I don't know how the off balance happened with the 14 to 20 days, but truly, we had no regrets because she did have a wonderful life. But for some, it was sudden because I thought she had 14 days. I was coming tomorrow, that kind of thing. But she knew and she's ready. We haven't had the funeral yet because they're trying to do the checklist of everything she wanted and who. It, it's a production, believe me, but that's what she wanted and she'll get it.
Thank you for sharing. Thank you for sharing.
Hmm. Yeah.
Dr. Perez and then Dolores.
I've had the experience of having children ask me if they were going to die today, and how their parents and their health team prepared them for that transition. And honesty um, and transparency has given me has made me feel better about the whole experience. I think it is definitely something, when a child looks at you and knows that this may be the end for them. Um, as I say that, the end for them, um, I'm trying to think of a child who thought it was the end. Most of the children were hopeful for something new. They didn't know what was coming, but they didn't expect it to be the end. And I'm just now reflecting on how courageous those little ones were. Um, Wow.
Okay. Thank you for sharing. Dolores?
You're muted.
Yes, I was just thinking of my mother. My mother knew that she was leaving, you know. She was happy and she she talked to us like I see her. I've been tagged and she went away smiling and happy. So I think some people really know, been, called in a special way that it's time. That's all I have to say.
Thank you for sharing, Dolores. Thank you. Okay. Any other comments? If not, we'll go to the next article. This it's an interesting article that talks about lady who had miscarriage and had post had what was called hysteria, but was really just a grieving process because she lost a child. And postpartum psychosis is uh, something that is occurs, and in the old days they didn't realize that it was a condition that needed treatment. And now we know that it is a grieving process, and postpartum psychosis can happen to anybody, whether you have a successful delivery or an unsuccessful delivery, and that we no longer regard it as hysteria, but we regard it, particularly if the child is lost, as a part of the grieving process. And then, of course, the postpartum psychosis can cause the mother to completely lose her mind and have depression that uh, gets her to run away from everything. So we now are wise enough to recognize that the grieving process is something that occurs at the end of delivery, sometimes at the end of a successful delivery, sometimes at the end of an unsuccessful delivery. John Buchanan?
Yes, I remember uh, back in, I guess, late 90s in DCPS, we had sessions with all the teachers about grief and how to handle, because a lot of students, there was a lot of violence and a lot of murders and things like that that we had to go through as teachers. And I thought it was very interesting that they had every teacher go through these sessions about how to handle grief and the stages, uh, and they made it clear that if you did not process those feelings, that it could be really dangerous to you physically and spiritually and mentally. The grieving process is uh, there's been a lot of study about it, so they definitely know that an important process. Thank you.
Thank you for sharing. Carol?
I know we had a session when we were meeting in person, and Maya did a paper on that about grief and how our society, particularly the Black society and some of the Black churches, were handling grief altogether wrong and not letting people grieve emotionally and outwardly. In some of the churches, they're calling it a celebration and be happy that they have passed, or they rephrase it and saying we're celebrating their life, their live, instead of actually going through the moments of grief. she did an excellent paper on that. And I have a second cousin who, when his grandfather died, he went into hysteria. Some people do actually go into hysteria when someone close with them and they don't know how to handle the grief. So consequently, he lost his job. And everybody said because he couldn't handle the grief and no one was there to make him handle it, they just say, man up, you don't cry, or you're going too well, and etc. But a lot of our institutions now, even at funerals, they don't want people to hardly cry anymore. They want them to be smiling the whole time. And I like that last article when the lady recanted and said, I want you to do cry. At first, people say, don't cry for me when I did. But when you cry, you're showing that you will miss them and you're showing real grief. But our mindset on grief, funerals, and all of that have completely changed in some of our cultures. And we don't give that family time to mourn, even particularly at the funeral or emotional.
Thank you for sharing. Any other comments about the grieving process? Okay, there's no more comments. We'll go to the next article. This it's kind of sad, although it's laughable, that we keep going from one extreme to the other. First, we say we don't want to do our mRNAs, and now we realize that it is scientifically something that we need to do. And so we now have the first RNA flu vaccine, which is the state of the art. And it's something that is long overdue. But it's good to see that we've overcome the ignorance of the Republican Party relative to vaccines and mRNAs. Carol, you're mute.
I'm sorry, I didn't lower my hand.
Oh, okay. All right. So I think this is it's good to see that in spite of their ignorance, they have decided to come into the next century and take advantage of a tremendous advance in science, which is the mRNA and the recognizing the advance that the RNA has over the DNA. Darryl?
Yeah. How long is the new flu vaccine with mRNA? How long are the effects supposed to last?
It didn't say in this article, but it appeared to me that this vaccine allows you to develop antibodies when the virus changes, whereas the DNA did not give you that capacity. But this article does not talk about how long the vaccine lasts.
Okay.
Um,
Just a
but
comment about the Republicans and vaccines. Trump stayed up to date on all of his COVID shots. But unfortunately, his followers resisted a lot of the shots, a lot of the vaccines, fearing autism from their children.
yeah, right. Thanks for sharing. Yeah, that's a problem that he and Kennedy have long talked about, but with no data to support their positions, and they're really doing all they can to promote that concept still, as they're trying to get additional studies to validate that concern over autism and the vaccines, which so far has not been substantiated. Dr. Perez?
I think it's very important the caveat that Brother Darryl just mentioned. He has stayed up to date with his shots, despite the fact that he advocates that others not do that.
Yeah, well, no comment. Any
I'm
other comments?
sure his children are up to date as well.
Yeah. Okay, well, it's at first they wouldn't even study the RNA vaccine, but they have changed their position, and it's good to see because it's time that here's this new technology that actually won the Nobel Prize in 2024, and so everybody else in the world is aware of the importance of it. So we're going to turn a blind eye to it. That doesn't make any sense. So anyway, it's good to see that they have moved forward in spite of their prejudice.
But there are also MMR, measles, mumps, and rubella, separating those three shots. Are you kidding me?
Well, what can I tell you? Yeah, that's what's causing us to have measles again, isn't it? So their ignorance is causing us to have many morbidities and mortalities.
And this policy will then lead to insurance companies not paying for the vaccine. So again, the poor pay the price.
Well, that has not occurred yet.
It hasn't occurred yet, but if it's not a recommendation from the CDC, many of these insurance companies will stop providing it as a preventive care measure.
Well, the
Now,
CDC,
from 18 to 11 vaccines that are no longer part of the child immunization schedule. If a parent can pay for the immunization, the other 7, they will. But if you can't, if you're making a decision between whether to get an immunization or food on the table, that's not fair. That
well,
is not fair. The development of most of this has come from our tax dollars.
what is fair about the
I'm saying
Republican
it's
position?
not fair that
Well,
if
what is fair
insurance,
about the Republican position?
I hear you. Vote, vote.
Um, what do you call it? You say you don't believe in something, but yet you do it yourself. Like he got the shots. It's
That's
not out of ignorance. It's just plain murder. Um, if you don't believe in something, then you won't get it. And you tell others not to get it because you didn't get it. But he gets it, but tell others not to get it. So that's just outright murder.
Hypocritical.
Thank you for sharing, Carol. Okay. This is another article that talks about homeless people being left out of the Medicaid work rule, meaning if you're homeless and you're not working, then you're not going to be covered by Medicaid, which is a tragedy. Another tragedy. Yeah, Carol was talking about uh, one tragedy. This is another tragedy because if you are homeless and don't have a job, uh, it's appropriate that you be covered by Medicaid, but uh, the recent ruling is that the homeless are left out of, in some states, left out of the coverage, which is another tragedy. But then there are many tragedies associated with the Republican administration. Yeah.
It's like the law that they had after slavery, particularly like in Virginia. You don't have a job. So if you stand around and you don't have a job, it's called vagrant, and they can arrest you. First, they won't give you a job. They know they can arrest you because they make a law in order not to, if you don't have a job, then you get arrested for vaping. Those laws are still prevalent today. It's racism. It's like they're there to kill, and they blatantly put out these laws knowing that there's no way that we can avoid it. And besides voting, first you got to vote these laws out because they're ludicrous.
Thank you for sharing, Carol. Any other comments about the other injustices? Okay, let's go to the next article. This is an interesting update that cyclosporiasis is waning, and therefore it's okay to eat lettuce and salads again from Michigan, which was the primary source of much of the cyclosporiasis which occurred. So things are getting so-called back to normal. We shall see over time if the outbreak is over. But there's evidence that the number of cases has decreased. Okay, let's go to the next article, I guess. This is an interesting article. It talks about how to avoid stroke. And it talks about, Betty uh, talked about what she doesn't do after 4 o'clock. This says after 5 o'clock, the things that you should not do. One is to eat a late dinner. Uh, the second is to not lounge on the couch. The third is not have a nightcap. And by a nightcap, they're talking about a couple of drinks. And then spending your night watching TV and not sleeping appropriately. They think that all those four things, if you'd avoid after 5 p.m., it would decrease stroke. Cardiovascular disease is the leading cause of death in this country and the world. And stroke is a form of cardiovascular disease. And they're recommending those four things to try to decrease the inordinately high incidence of strokes, particularly in our patient population where hypertension and diabetes is rampant. Any comments about these things that you should avoid after 5 p.m. to decrease the likelihood of stroke? And it fits for all of the cardiovascular diseases. Any comments about this practice, although it makes sense? Yeah. No comments. The next article talks about the GLP-1 drug that actually lowers the risk for cardiovascular events. This is something that is true for diabetics and non-diabetics as well. And uh, as we have more experience with the GLP-1 drugs, we'll find out even more things that the drugs are good for, and also the side effects, and that we need to worry about. But this is one of a number of studies that demonstrates that peripheral vascular diseases and cardiovascular diseases are decreased, mortalities are decreased as a consequence of this GLP-1 drug. This is an article that compares GLP-1 drugs and the SGLT2 inhibitors, and they saying that whether it helps or not depends upon the type of kidney failure you have. And as you know, we have 5 stages of kidney disease, and whether you're in stage 4 or 5 or 3 makes a difference. For the most part, the first 3 stages of kidney disease are reversible when you know what's causing the kidney failure. Stage 5 is not reversible, and stage 4 uh, is not thought to be reversible, but on rare occasions, you can keep it from converting to stage 5. But stage 1 through 3 are reversible if you find out what is the cause of the kidney failure in the first place. And the first 3 stages really revolve around a creatinine clearance of greater than 40. Yeah. And it is interesting that management of the causes of the kidney failure vary. And if it's diabetes or if it's hypertension, management of those conditions can allow for a reversal of the stage of kidney disease if it's in the first 3 stages. Any comments or questions about kidney failure? Of course, we mentioned last week that 36 million Americans have kidney disease, and people of our ethnicity have 4 times the incidence of kidney disease and hypertension and diabetes than anybody, than all other ethnicities.
Dr. Callender, this is Carlin. So are do they do you or how do you know whether one of these GLP-1s or what's the other one, the
SGLT.
SGLT would help if you are dealing with I don't know, say stage 3?
Well, I think if you know if you have diabetes or if you have hypertension, uh, treatment of those 2 things by either the inhibitors or the GLP. If it's diabetes, the GLP-1 drug might be the choice. If it's hypertension, the SGL2 inhibitors might be the choice. But so far, the data has not really been good enough for us to say, okay, uh, we're absolutely positive that this will work if you're diabetic. We're absolutely positive this will work if you're hypertensive. But I think one of the biggest problems with this is that you don't always know what is the cause of the kidney failure. And that is the biggest problem of all. When you know that you have hypertension as the trigger, then you know what medications to use. If you know that diabetes is the trigger, you know what to use. It's when you don't know what is the cause of it that it then becomes more of an issue. Uh, for example, having focal sclerosis and glomerular cirrhosis, which is a common concern with people of color, that then becomes a mitigating factor as also if you have chronic glomerulonephritis, that becomes a different factor as well. So So that's why it becomes complicated, Colin, and why I can't give you a good answer to your question other than what I shared. Any other
Thank
comments? Any other comments or questions? A very good question, and it's a topic that we're going to see more and more as we have more experience with both of these types of therapies. Now, this is an interesting new topic of wanting to have FDA oversight of dietary supplements. And this has become an issue because many of the dietary supplements are not monitored. Or if they're monitored after the harm is done. And there's no prior uh, sanctioning or approval of dietary supplements. And this article is calling for there to be an FDA oversight of dietary supplements because some of them are causing harm. And whether this will actually take place or not, uh, to me, it's doubtful uh, because the Republican administration doesn't seem to want to do any additional stuff. It doesn't do all the stuff that it needs to do. So to ask them to do something additional is an interesting request. Although I think it's valid because I think supplements that can harm people uh, are present. And so we need to have uh, some oversight before these harmful supplements are actually released to the public. But there's no such thing right now. And so this is a request that will be interesting to see if it falls on deaf ears. Any questions or comments about dietary supplements? And
I had a comment, Dr. Callender. Um,
yes,
you know, just having the supplements out there, you can get them at the grocery store now,
right.
and to me a bigger problem is the interaction between the different supplements. What could happen. It seems like there's no control at all over what might happen if somebody takes one that's in conflict with another. Thanks.
And you've accurately stated what the article is considering the major problem. Uh, I just don't foresee the FDA taking this up since they can't handle what they need to handle. So taking this up, which is appropriate, is something that I think is necessary, but it's going to be interesting to see whether they will be interested in taking on another assignment. Darryl?
Yeah, it's important to discuss your supplements with your doctor. Uh, John Buchanan says he takes all of his medications, his prescription medications, but take your supplement medications too, and ask your doctor uh, for advice on the supplements that you're taking because you may get some uh, counter interactions, and some supplements can be very deadly, especially when people take way too many of it when they're self-diagnosing and self-medicating.
Thank you for sharing. Any other comments? If not, we'll go to the next article. This is a surprising article on iron. Iron deficiency and anemia is one of the commonest anemias that we have, and uh, the presumption is that if you have iron deficiency, you take it. Uh, but that requires you to get an iron level to find out whether you're iron deficiency or not. And a low iron deficiency can be because of blood loss. And so if you have iron deficiency, it's important to know what is the cause of the iron deficiency, because if it's just that your iron level is low, you can take iron, ferrous sulfate, and those kinds of products, just as John had to do in order for him to do his blood transfusions. But you wouldn't know that if you didn't get a iron blood level. And the treatment, of course, is ferrous sulfate or an iron-containing drug. And the way to monitor it is to have your iron level drawn so that you can know whether you're taking too much or too little. And so having your hemoglobin monitored is a way, and your ferritin level monitored are ways of identifying whether or not you need iron or not. And so this is something that is often presumed, but is important to know. Hemoglobin is one of the first ways to monitor iron level, but ferritin level is the uh, absolute test that identifies whether it's uh, blood loss or just iron deficiency. Because when you lose blood, you lose hemoglobin, and when you lose hemoglobin, you lose iron. And so, question is it blood loss or is it iron deficiency? And the iron deficiency is treatable by iron. Whereas if you really are losing blood, then you need to find out why. And yes, you're going to have problems from overdosing iron as well, anything else. Okay. There are no other comments on that. This article is a little confusing because cholesterol level, you should know. I guess the things you should know your hemoglobin A1C or your blood sugar level. You should know your cholesterol levels, and you should know uh, your GFR. I think those are things that you should know. Now the LDL, there's HDL and the LDL. The LDL is the one that is not good for you if it's elevated. That usually is associated with hypercholesterolemia and is associated with a higher mortality rate, of course. In this particular article, they point out that often the high LDL is not associated globally with increase in mortality, which is a surprise because traditionally, when you have an LDL that's greater than 200, it's associated with mortality. And so the treatment is to get the cholesterol level under 200 so that you're not, you do not, you do not have the high mortality rate. Of course, the LDL and the HDL is thought to be associated with a high HDL is good for you, a high LDL is bad for you. And so we want to have a high HDL but a lower LDL. But this article is suggesting that even though the LDLs are higher globally, the mortality rate is not particularly high in spite of that. And, uh, what is the cause? We're not sure, but we still feel that if your LDL is up, that you need to be on medications to reduce the cholesterol level because it is associated with a lower mortality rate if the LDL is less than 200. Any comments about that, Darryl?
Yeah, I think increasing LDL globally is being driven by potato chips and French fries.
Yeah, it probably is. Yeah, yeah. Uh, do you see any likelihood that that's going to change?
Well, if you take the no French fry, no potato chip pledge and stay with it, uh, I've taken that pledge. I'm staying with it.
Uh, yeah, well, it's sometimes tough to do, but it's worthwhile, as you point out. But talk is cheap. Uh, uh, where you do it, that's the question. Uh, okay, well, any more comments? If not, we'll go to the next one. This is a rally about uh, AI created messages that seem to be okay if the clinicians are involved. And that to me is one of the important issues. AI is in its own is it has its merits, but particularly of great value when the clinician is part of the AI. When it's AI alone, I'm not happy with it. But when it's AI plus clinical oversight, I think that's valuable. And the more we have physician oversight and the better we have the I think the better off we both are because it's a combination that's good. AI and the clinician oversight is a good combination. AI alone right now is not the way to go. Any comments? Because I think this is something that has been wanting. Sometimes you have the AI and not the clinician oversight. Together, they're great. One without the other is not desirable either. You want to have the physician, but you want the AI as well. You want them both to be in partnership to get the best results and the best consequences. Any comments or thoughts about AI with or without uh, clinical oversight? No comments? No comments. Well, our future lies in the combination, the two working together for the best patient results. Okay, let's go to the next article then. What skills will be relevant in the age of AI? And it's interesting because this article just points out that uh, the skills that you have are important to have to work together with the machines. The machines alone can't do it. Machines and people together, leadership skills and working with people is something that is very important. And this article talks about imagination and emotional intelligence as being an important part of uh, patient care. And I don't think that can be overestimated. Any comments or thoughts about the interaction of the artificial intelligence and the clinician and leadership and so everybody's in agreement that the two components together make for the best result. Janice?
No, I don't have anything.
Okay. All right. All right. Now this is an article that I thought was, I think we had it last week, but somehow we didn't cover it. But the impact of weighted vests on bone health, and there's much data that suggests wearing weighted vests as you walk and run around makes a tremendous difference in bone health. Uh, and it's something that is relatively recent. The recognition that wearing weighted vests can help your bone health. Uh, Walking and all those other things alone have not demonstrated any effect upon bone health. But wearing the weighted vests and walking around has demonstrated bone density benefits. And so as a consequence, this is something new that we should be more aware of. Any comments on this? Anybody, any of you exposed to using weighted vests as you walk around to increase your bone density? As we know, as you age, you have bone loss and muscle loss, and this is one way to address the bone health issue, which, as you age, becomes a very important issue. We're seeing, and there's another article that talks about the importance of more intensity, high intensity weight exercises being important for bone health, whereas the just traditional walking around does not improve bone health. So the weighted vests and the weight resistance exercises with bands is now something that is thought to be necessary if you want to increase your bone density. Any comments, Joyce?
I want to thank everyone for your comments that I had with last time we had this discussion, and I just want to give everyone an update to where I am. I am in my evaluation period. So I would say within the next couple of weeks that I will be taking my bone density therapy sessions and medications. So we'll see how it goes.
Okay, thank you for sharing. Any other comments? Okay. Well, we'll go to the next. We'll see what happens with Joyce and the rest of us. Okay, let's go to the next article then. And this is the article that talks about uh, handball and strength training in order to increase bone health. Light exercise apparently is not enough to increase bone health. And as we age, we know that bone density decreases. So these more high intensity exercises and weightlifting become more important. And this article details how that's the case. I know that Darryl does both. So any comments, Darryl? John?
Yeah, how do they measure bone density?
Oh, they have a bone densitometer. You go and there's a special MRI that addresses the bone density, and they give you a measurement. And if your measurement is below a certain measure, that means your bone density is low, and you need to, as Joyce is doing it herself, they look at your bone density and see whether it's normal or not. And if it's low, then they recommend medication and uh, things like the weighted vests and intensive exercises to increase the bone density. Dow?
Yeah, my feeling is that it's a delicate balancing exercise once you get in your 70s and beyond, because you need the cardiovascular activity, but when you do that, it's not strengthening your bones, and you need the strong muscles and tendons to support it. And so you need to do the stretching exercises, and it helps to do the resistance training so that you have the muscles. You have to be very careful with resistance training. The older you get, the less weight you need. You may have been able to do 150-pound bench presses when you were in your 30s, but you get in your 70s, and it could be a 40-pound bench press, 50, 60, but you don't, overdoing it can really set you back because you get those back strains, those knee strains. And then you say, I can't do my walking, I can't do lifting until it heals. You start back too soon, and then you aggravate it and you delay your recovery time even more. So the older you get, less is more, but you got to do it all just to avoid those daily aches and pains. You don't want to be say, what's your problem? The problem is I got out of bed and I hurt myself.
Yeah. Thank you for sharing. Very important information because as you exercise, you do all of those things that he mentioned. And and when you get to the point where you can't do those other things, then you're really in trouble. So take heed. Right. And
Yeah.
what do you think is the lowest amount of weight you can lift without damaging yourself?
Well, it depends on what you're doing. If you're doing some lateral raises, 5 pounds in each arms, you're doing enough. If you're doing, a couple of sets of ten lateral raises, that can be enough. For women, if they have 2 pound, 5 pound, 10 pound weights, for a woman that could be enough. Um, Men in the 70s, if you're just looking at dumbbells, uh, unless you're just really in shape, you don't really need to have something. You can get by a lot with up to 25 pounds in dumbbells. Uh, if you're using barbells on a bench, um, but the important. My point is, it doesn't take a lot of weight. But if you're a man or woman, you get in your 70s, you need to have some type of weights, whether it's a weighted vest, some dumbbells or something, and do it regularly. Find some routines because it could be so beneficial. It can make the quality of your life so much better that you don't have these aches and pains that, just terrorizes us when we get in our 70s. You can have uh, like the way it should be, you get in your 70s. And it should be that you don't have any aches and pains, but it doesn't come by magic. You got to work to get it.
You're so right. I'm 89, and when you go too far extreme, you pay for it. And uh, it's nice to be 89 without aches and pains. And sometimes when you overdo it, those aches and pains come. So take heed to Darryl. He's giving you good advice. Okay, let's go to the next article. I included this because I wanted us to take this test on prevention of dementia. What is the strongest modifiable risk factor for dementia? Smoking, air pollution, less education, or hearing loss? What is the best answer? We've answered this on many occasions.
Hearing
Darryl,
loss.
huh?
Hearing loss.
Yeah, right. Yeah. We've discussed this on a number of occasions, and it's something that men have a tendency not to want to address. But hearing loss, yeah, okay. Which is now considered a risk factor for dementia? Anxiety, lipoprotein, LDL, hormone replacement therapy, post-traumatic stress disorder. And it's the LDL that which usually treated by statins to get the LDL down to normal levels. So then which proportion of dementia can be prevented or delayed by modifying the 14 risk factors identified by the Lancet Commission? Small but significant minority, nearly half, approximately three-quarters, nearly all. And the answer is nearly half, yeah. And it's interesting that we talk about that in terms of the 14 factors. And then this is the question that many would miss. What is the recommended systolic blood pressure to help reduce hypertension and thereby lower dementia risk? 110, less than 110, less than 120, less than 130, less than 140. And the best answer is less than 120, even though we've had many studies that have looked at all of those, but the best answer is actually less than 120. Which statement best reflects the evidence linking alcohol consumption and dementia risk? Any amount of alcohol consumption increases dementia risk. Light to moderate is consistently protective against heavy alcohols is associated with increased dementia. People who abstain from alcohol have the lowest dementia risk in all studies. And many people think that any amount of alcohol increases dementia risk. But this is an issue that has come up for much discussion because there are those, as you say, the Bible says, a little drinking is good for the stomach's sake. But most of the studies that have done since that have demonstrated that the best alcohol is no alcohol. But anyway, just thought I'd include this so we'd have a discussion about the impact of alcohol. Much of the work that's been done on this is done in UK, but now this is a recent article that links angiotensin receptors and statins to a lower dementia risk. Many people are on statins. Not too many people are on angiotensin receptors as well. But this is a study that was done in Australia, and whether it has relevance to people of color, I can't say. But anyway, in Australia, they did find that there was this association. Interesting to notice too. We'll see how whether this is applicable in the United States. This is an Australian study, so. Yeah, that'll have to be the last paper. I've got to go to but I guess this is the last because smoking, hypertension, and diabetes are the three factors that are tied to 13 more dementia-free years in a prospective study. So keep that in mind. Normalize blood pressure. Keep your hemoglobin A1C 6 or thereabouts, and stop smoking. And with that, I'll close and thank you all for being with me today. And see you again next week, God willing. And have a great week. Okay, it's good to have you back again. We missed you. And Dr. Perez, good to have you back too. All right.
Be
Thank
safe,
you.
everyone. Bye-bye.
Okay. Bye.
Bye bye.